Assalamu alaikum everyone. So we were waiting for some audience to join us. Hopefully our sessions will be very good for you. My name is Rehan Anjum and I am clinical pharmacist at Shifa International Hospital. Thank you everyone for joining our sessions and make this event a great learning experience for everyone across the Pakistan. We have so many pharmacists and giving feedback to us that these sessions are helpful. Actually, we want to grow up our pharmacy community in terms of continuous professional development and these sessions and our other activities like eminent pharmacy lecture series, our workshops, conferences. Hopefully that will also be helpful for you. So we will start our today's session that is about common lab interventions for pharmacists. As I have introduced myself, Rehan Anjum from Shifa International Hospital. I am a clinical pharmacist at Shifa International Hospital. I'm also working as a clinical pharmacy lecturer at Shifa University. I am also looking the residency program at Shifa International Hospital, which we are looking to be accredited by American Society for Healthcare Pharmacists at ASHP. So, inshallah, soon we will be accredited. And that's all about myself. So in today's session, I will be more focused about the points or the agendas or the things that a pharmacist should look into it to give a better patient care. So we will start. I think so most of our audience is from Pakistan, so I can switch my language from English or do anything. It will be a mix-up. So disclosure, the information present in this presentation is for general audience, is general guidance only. It is essential to take professional advice on specific issues and their impact on any individual or entity. No financial interest or affiliation concerning material discussed in this presentation. And the learning objectives of today's activity would be the importance of a laboratory data for pharmacists and interpretation of the laboratory values, common labs for a pharmacist that a pharmacist should know, and making interventions from the data. That's the main point that I want you people to learn, because the laboratory values are helpful for us to guide us to make necessary therapeutic changes or to change our therapeutic choices. So in the end, I want that you people will be able to make necessary interventions by this session. So let's start. Why we need clinical laboratories? What's its importance to have some laboratory values for us? Laboratory values help us in different things, and we are well aware of it, that how it is important. First of all, if we say that about diagnostics, we all are familiar that for diagnostic, if we say that if a patient has HbA1c of 8, 9, oh yes, he has a diabetes, so we have to use insulins or etc., or he has a diabetes. But what is for the pharmacist? In case of diagnostics, if you are dealing with a patient and you come across a patient and you suspect that either he or she is diabetic, so you could ask to have this test. So for diagnostics, it is diagnostics also help us to make our changes to guide our therapeutic choices. And about baseline measurement, baseline monitoring is required, because when you're giving a medication to the patient, it might be that this medication might change the physiology of the patient, or there might be some changes in different parameters like ACE or ARBs. If you're giving them, you should expect that there would be a raise of creatinine about 30%. So you should expect what kind of changes would be there. And same like it is one thing. The other thing is that it is kind of like what type of goal you want to achieve. The baseline was, let's suppose HbA1c baseline was 7. Now after starting in diabetic therapy, now it is 6.1. So baseline monitoring is also required. And the other one is the monitoring. The monitoring indicates the progress towards therapeutic goals. For example, decreased total cholesterol and low density lipoproteins, or increased high density lipoproteins, elevated INR and INR with warfarin. Okay. So toxic or subtherapeutic concentrations of medication, that's an important point to be considered while dealing with the medications that are toxic. You should ask for the laboratory values. You can say it, you can name it as a TDM as well, that you are measuring the therapeutic concentration of the drugs to find that whether the patient have a toxic level or not. Like a patient can, you receive a patient in ER, and he's unconscious or comatose or in coma, whatever it is. So family is saying that he has taken some kind of medications. So in that case, you will ask to have some levels. Like, let's suppose if it is benzodiazepine, so the presence of more than 200 levels benzodiazepine indicates that he is toxic. And the other thing is the subtherapeutic concentrations of the medications. As we all know and very well aware of the MICs, etc. So in that case, it is also helpful for us. Why to ask for a laboratory test? That's very important. Laboratory test के लिए क्यों कहा जाए? In situations where tests could impact medication therapy, this is the very good point. I would say that where medication could, where tests could impact medication therapy decisions, or medication therapy might alter the testing results. I would explain it later. Pharmacists should review relevant tests that are required to make this determination. So it helps us in selection of drugs. Let's suppose if I say, as I told you, that we come to know that a patient has a deranged liver functions. So we'll try to use medication that is less hepatotoxic or might be hepatoprotectant. So it helps us in selection of the drugs. Avoid adverse effects. So avoid adverse effects is the same thing like if a ECG is a test, we can find QT prolongation and the drugs causing QT prolongation. In that case, it might help us, or X-rays, etc. Medication adherence, that's a very good thing that we can take help from the laboratory data in finding the medication adherence. You come across a patient who says that I am taking this medication and I'm not getting relief. So in that case, you can have his or her levels, and you can come to know that okay, his or her levels are not achieved. In that case, he might not be compliant, or he's not taking those medication accordingly. You should intervene and make necessary adjustments. Drug abuse, you can find it by drug abuse. We can find drug abuse like as I said, that sedative mostly in our society. Benzodiazepines are used as a sedatives, and but they have a high potential of drug abuse. People are abusing it. So in that case, you might ask for the laboratory to confirm the drug abuse. And monitoring the therapeutic outcome, it is again that you measure the levels and you say, okay, uh, have the blood pressure monitoring. Okay, we have given some drug to you, and okay, no blood, your blood pressure is fine or not. So diagnosis, and ultimately that is the better patient outcome. So these are some examples for which we need laboratory tests. Now we will discuss them a little. Individualizing drug dosing. The first thing that is very important, that is a kind of therapeutic drug monitoring, that serum drug levels for medication with narrow therapeutic index, or with drugs that have a high protein binding, or with the steep dose curves. In that case, if you increase a little bit of the drug, then you may get enormous effects that could be devastating, and that could come harm to the patient. In that case, you should be careful. So the laboratory test helps you to have individualizing drug dose. That might be a patient need 1 gram twice daily of vancomycin, the other might need 750 mg twice daily. So it helps us. And the most common that we come across about the warfarin patient, that is in also in our ambulatory care or inpatient hospital everywhere, where warfarin is prescribed to the patients. So in that case, you monitor the levels of INR and you individualize the dose. Okay, no, its level are achieved, okay, we will continue with this dose, or its levels are not achieved or it's below, then we'll increase the dose, or its levels are high, then we will decrease the dose. So these are the examples of decreasing, individualizing the drug dosing. The other most important, the renal and hepatic function. Other than this session, I would say that we should focus about renal hepatic function test for medications, because there are a lot of medications that require renal and hepatic dose adjustments. So if a patient is renally compromised, then he or she might not be able to excrete those drugs from the blood, and there might be accumulation, and that could result into toxicity. So laboratory test helps us in utilizing drug dosing. Culture and sensitivity results for antibiotic therapy. This kind of choosing the drug, while cultural sensitivity test is very important in selection of the antibiotics. So in that case, you could come to know that this kind of antibiotics will be effective for my patient. So being a pharmacist, you should ask for some tests if you think that it is required. So as I told you earlier that in diagnosis, like you are dealing with a patient and you suspect something, like either the patient diagnosed with a new onset asthma with very little symptoms and no history of spirometry testing. So you should ask him to have a spirometry testing to look for asthma. Or if a patient comes to you to have a Ventolin inhaler and he says, I'm using it and I'm getting fine, you should ask him to go to have this proper test. So, and other thing is that patient with a diagnosis of type 2 diabetes and no response to oral diabetes medication are very widely fluctuating glucose levels with minor changes in insulin dose. No history of insulin antibody or C-peptide testing. So it is most likely that patient might have a resistant diabetes. In that case, a very high dose of insulin might be required. Even we have used about 5 units per kg, that is 300 units per day to some patients as well. And you should also look for the adverse drug reactions, like you know that some drug that could cause this kind of side effect. So you should ask for those tests, like amiodarone, it causes pulmonary fibrosis. So you could ask that you should have a chest X-ray for this. Another thing is the medication safety and monitoring. I know for change in medication, diet, healthy, that may affect warfarin therapy. So if there is a patient who had any recently change in his medication, diet, or anything, so in that case, you could ask to have his or her levels. And with some kind of drugs, you must ask some kind of levels, like chemistry panel for patient with recent changes in doses of diuretics. Diuretics, ACE, ARBs, as I told you earlier, that these drugs could affect labs. So in that case, you should ask for the laboratory values, or if you are working in an organization, or if you have the resources available to check the laboratory values, you should check. And you should also go for, let's suppose if a patient has a liver function test, you should look into it, because by using TB treatment, and the most of the ATT drugs can cause liver injury. So the drug that could cause liver injury, in that case, you could use it. And urine drug testing screening you could use for the monitoring, and ECG for QT prolongation. And especially while working, my presentation is more focused to those pharmacists who does not have so much of resources available to have these tests available while dispensing the medications. But you should be careful while dispensing the drugs. Let's suppose if I say that valproic acid. So if you say about the valproic acid's black box warning, then it says that it is contraindicated, or it should not be used in females of childbearing age. So if you receive orders of a valproic acid, and there is a female about 20 to 40 years, or might be 50 years, then you should ask that about the pregnancy test, whether if she is pregnant, or if she is planning to be pregnant soon. So in that case, you should be careful about these tests, that pregnancy tests for all those drugs that are teratogenic or that could cause fetal harms. And Lab monitoring is also required for alcohol use disorder. You should monitor these as well. Along with it, attainment of patient-specific treatment goals. We order lab results for attainment of patient-specific treatment goals like A1C to check that whether our patient has attained this. We could ask about INR, thyroid function test, uric acids. So in that case, you could also ask for the laboratories. So these was something basic about the laboratories. Now we will try to move on bit at the next level, inshallah. Normal values may vary from laboratory to laboratory, and depending upon techniques and reagents. You must be aware of the laboratory normal ranges as well. What kind of the normal values for that laboratory might be. One laboratory use another technique and other laboratories using another technique. So you must check with the normal reference ranges given by that laboratory. Normal values may also vary depending upon the patient age, gender, weight, height, and other factors. These are the factors, obviously. Let's suppose if we talk about the serum creatinine. So creatinine is a byproduct of the muscles. So if a patient is very much healthy, so might be his or her creatinine, serum creatinine is very high. So you should take into account these things also. About there are some labs that are affected by the genders or some kind of hormones that may vary for your age. So, and you should also know that human errors or lab errors could be possible when you find there is a too much difference between the initial baseline laboratory value and no. So you should be careful about it, that it could happen. So potential causes of laboratory errors may include technical error or improper calculation, inadequate specimen, incorrect sampling timing, or something like if we had taken some food or medication interference with the laboratory test. So if a laboratory error is suspected, the test should be repeated. And one thing that is a golden rule, that always treat the patient or the laboratory values. So always treat the patient or the laboratory values. We will discuss it more. I can exemplify with the anti-epileptics that there are certain levels that you have to achieve for anti-epileptics. Like if it is for valproic acid, then your levels must be between 50 to 100. But in case your patient is settled at 30, then you should not try to make it to 50 or 60. Might be you end up in causing toxicity to the patient. So interpretation of the lab results. Lab results are usually reported as numerical values, and you must know about it, like 139 MEq per liter of sodium when it is numbers, and sometimes it is reported as descriptive, like it is gram positive, cocaine gram negative, and at times when there are diagnostic tests or X-ray or radiographic tests, they have descriptive result, and you should know what kind of units are being used. That might be like most of our institutions are mostly the blood sugar level are measured in mg per deciliter, but at different sites it is also made as millimoles. So you should know what kind of units is being used, and you should know the reference ranges can vary slightly from one facility to another and between pediatric and adult populations. Like and about the laboratory values, you should know that this is a specimen with a vancomycin level, and you see that there are three levels for vancomycin. One was 25, other was 14, and other was 34. So if you look into the trough level or the peak levels, trough levels in vancomycin, we are really interested in our trough levels. If we are more interested in toxicity, then we would look for the peak levels. So for trough levels, it should be 10 to 15, or now it is changed to 10 to 20, or it is severe infection, it could be up to 25. So in that case, you see that there are three levels. One is 25, that is high. Other was 14, that's okay, that's fine, and 34 was again high. So in that case, you may need to change the drug dose of the drug. So common labs that a pharmacist should know. These are the common labs I would suggest every one of you to learn if you want to make uh, intervention to the patient care. There are a lot of laboratory values and as much you can learn you should learn, but these are some of the basic labs I think that you should learn. That is chem 7. It is a metabolic panel. I would discuss later. Complete blood count, that is you can say blood test or renal function test, liver function test, culture, therapeutic drug monitoring levels, lipid profile, diabetic profiles. ABGs is the arterial blood gases that might be helpful for inpatient, but not for OPD patients because not being used frequently. I think so. It's not done in OPDs. And COPD, like ABGs for COPDs, and calcium, albumin, and bone marrow densities and coagulation tests are very important. So we will start with the CAM7, that is our metabolic panel. Our metabolic panel consists of these 7 values, that is sodium, potassium, chloride, bicarbs, blood urea nitrogen, creatinine, and glucose. These are very important values that one should learn because it gives you an insight to make necessary changes. So you should know what are the basic values. So if I talk about the sodium, then a high sodium is known as hypernatremia, a low sodium known as hyponatremia. Hypernatremia and hyponatremia are very severe cases to treat. But usually you should know what kind of hyponatremia you have to treat. It could result into confusion, shock, etc. So always check before dispensing any drug that could change the sodium levels, like if it is a hypertonic saline, or if you are giving any hypotonic drug that could decrease. If a patient is already hypotonic, already lower, have lower sodium, and you're giving a drug that's all deficient with the sodium, so the patient will result in more hyponatremic state. So you should be careful. And you should know, let's suppose that there is a normal range is 135 to 145 MEQs per liter. So but you should know that what is the reference range for my indication as well. Let's suppose if I say about the reference range for sodium in to make osmolarity high at a higher level in patients with cerebral edema, etc. So you might have a sodium level around 155 as well. So in that case, you might go extend. You may increase it, and you also know how much you can change, and you should. The change in sodium shouldn't be 10 to 12 MEQ per liter per day. So you should know about the sodium levels. Along with it, the other one was potassium. Always check before dispensing any medication that could result in hyperkalemia or hypokalemia, same as sodium. So in that case, there are if you're working in an inpatients, then you will say that you will see there are multiple KCl influence. So you should be careful while dispensing anything that has to do with the potassium that could increase or decrease. So KCl, while dispensing, you should check potassium levels, and you should also know about the drugs that could cause hypokalemia. And there are multiple drugs that could cause hypokalemia. Let's suppose we say about most common drug, that is Lasix. Lasix cause hypokalemia, and the other drug that we use is the potassium sparing diuretic spironolactone that cause hyperkalemia. Along with it, you should look about the chlorine. Usually hypochloremic patient are not hypochloremic. Usually they are hyperchloremic. In case they are hyperchloremic, then it could lead to hyperchloremic acidosis. So in case of hyperchloremic acidosis, and the other thing was bicarbonate. Bicarbonate and chloride, they usually help to maintain a balance. And the other thing is blood urea nitrogen or creatinine, and the creatinine. These help us as a part of a metabolic panel. And the creatinine is most important. I would say that creatinine actually represent the kidney's function. While looking at the pharmacokinetic profile of the drugs, we know that administration, distribution, metabolism, and excretion. So creatinine represents the kidney's function. So if a patient's kidney's function is not good, then he or she is not able to excrete the drugs properly. So you should know. And for every pharmacist, I would say, if you don't have any access to sodium, potassium, etc., but you should ask that, or you should take hint that if a patient hint mean if a patient is coming to you with some drugs like calcium acetate or calcium 4, that's the phosphate binder used in CKD patients. So if you, that could help you to have an indication that patient does not have a adequate renal function. So you must know the normal creatinine value, that's 0.6 to 1.2 is for males, and 0.6 to 1.1 for females. And so anyone that has more than 1.2, you should make necessary changes in doses. So I will discuss it more in next 1 to 2 slides. But before that, I would say that you should also look for the metabolic panel about calcium, magnesium, and phosphates. If I say about calcium, then you should look check calcium levels before dispensing any medication that contains calcium. For example, I said that calcium acetate, calcium carbonate, that's most commonly used in ambulatory cares, that calcium carbonate, I think so. I'm not aware of that brand, but that is a chewable tablet of 1 gram. I think so. Chuko might be. I'm sorry about the using names, but calcium carbonate tablets we also take for calcium supplementation. People take it as OTC, but you should be careful about these drugs. And also for the drugs that decrease the calcium level, like bisphosphonates and cisplatin, and common medications such as hydrochlorothiazide and other thiazide diuretics prescribed for hypertension and edema can result in hypercalcemia. So you should know that what kind of drugs are adequate for my patients. And if I say about magnesium, magnesium is the main role in our muscles movement. So high magnesium levels could block the muscles movement. So you should be careful about dispensing magnesiums, and always check before dispensing magnesium. I mostly use magnesium sulfate, magnesium chloride. So whether it's IV or oral, so you should look. And for you should also look that if a patient has a hypomagnesemia, magnesium wouldn't be rectified, so magnesium will not become normal. There are also many drugs that could cause hypomagnesia. That includes amphotericin B, cisplatin, cyclosporin, tacrolimus, and loop diuretics, etc. If we talk about the phosphorus thing, and the phosphorus are part of bonds, so usually hypophosphatemias are managed by the use of potassium phosphates or sodium phosphates, oral or IV supplementation. And in case of hyper phosphatemia that is associated with the CKD, that is managed by the use of phosphate binders like calcium acetate, calcium carbonate, sevelamer, so calcium malignate, that could be used as a potassium phosphate binder. Sorry. Now, we will talk about renal function tests. In the last slide, I have said about serum creatinine. So here you are looking at that a patient has a serum creatinine of 1.5 mg per deciliter. So interestingly, if a patient has higher levels of serum creatinine, his creatinine clearance is low. If we look at the formulas of creatinine clearance, then you might know that if I could find just give me a minute, please. Pointer option. Okay. If you look at it, that age 140 minus age into weight divided by serum creatinine. So here is your serum creatinine. So when there's higher serum creatinine, your creatinine clearance is low. You should know the formulas to calculate of kidneys functions, and other which kind of formula you are using. So you should know for adults there's another formula, for peds there is a Cograft called formula, and for peds we use Schwartz bedside formula, and there is also a different formula used like for EGFR calculation. So you must be careful while dispensing the drugs that whether creatinine clearance are used or Coagulation equation is used. These are some kind of the drugs that require renal dose adjustments if a patient has higher renal function, high serum creatinine, so you should adjust the doses. And for your ease, if I have to summarize it, that all antibiotics require renal dose adjustments except ceftriaxone, clindamycin, cloxacillin, moxifloxacin, doxycycline, linezolate, chloramphenicol. So most of your antibiotics require renal dose adjustments. So you need to adjust the dose. And other than this, there are multiple other drugs that require renal dose adjustments, like ranitidine. So that's now out. Rivaroxaban, metformin, gabapentin, allopurinol, and even our apixaban. That's for yes, apixaban has some kind of factor in it, and atorvastatin, all kind of statins except atorvastatin, that does not require renal adjustment. If your patient is receiving rosuvastatin and he has deranged kidney function, so you should be careful about it. This is a brief chart we are using at Shifa International Hospital in adjusting doses. These are some of the antibiotics that need dose adjustments at different creatinine clearance. So that's fine. Know about liver function test. You should look for the liver function test because there are multiple medications that cause renal function. If you should look for AST, ALT, albumins. For making those adjustments, you should know that there is a score exists that is known as Child-Pugh score. Use that to calculate the extent of the liver injury. If we say about kidney function, and if you see that there is high SGPT, it could be that the drug is causing the liver toxicity. If SGPT is raised 2 to 3 times from the baseline, then hepatic dose adjustment or drug discontinuation may be warranted. An example, if we say about which kind of drugs that are hepatotoxic, about allopurinol, aminophylline, metronidazole is also hepatotoxic. Clindamycin, cyclophosphamide, propylthiouracil, and recently there's a lot of use of remdesivir. That's also hepatotoxic, and there's a criteria that if your AST/ALT is more than 3 times of the upper limit of natural, then you should discontinue. These are some kind of drugs. No, complete blood count. If we talk about the complete blood count, then the complete blood count is commonly ordered as a lab panel. In our lab blood test, I would say that is more easy to understand at RCBC. There is a differential, there is a detail about our red blood cells, our white blood cells, our type of cells presence. So, and these help us to individualize our drug dosing as well, how it is. This is a fishbone diagram that is most commonly used, that I would say to use a pharmacist, that there is a white blood cells, hemoglobin, hematocrit, and platelets. Along with it, if it is a differential CBC, then there is a neutrophil, lymphocytes, monocytes, eosinophils, and basophils. Hemoglobin, that most commonly we are estimating our blood. Okay, I have so much of blood, then that is by hemoglobin. So and the normal ranges differ from different laboratories. So usually it is from 12 to 16 gram per deciliter for male or females. I could say as an average, but females usually have lesser hemoglobin. So how you will intervene, being a pharmacist, how you will intervene with the help of hemoglobin values. So check hemoglobin while dispensing any drug that could increase hemoglobin levels. Let's suppose erythropoiesis, erythropoietin alpha, erythropoietin beta. So in that case, you should be careful. You should also be careful about drugs like with a much of iron load, like iron sucrose, etc., folic acids. So you should use them according to the guideline. And keep on, you should also keep an eye on drugs that could cause anemia, like ribavirin, trimethoprim, sulfamethoxazole, chloramphenicol, and ganciclovir. So let's suppose if your patient is getting such drug, and if your patient is on with hepatitis, is he is receiving ribavirin and he's also anemic, so you should consult with the doctor as well. And another thing is that it could also help us to monitor. Let's say the patient you received with a patient with the GI bleeding, and you check his or her HP levels, and that are stable, then it is an indication that your drug that, let's suppose here we are using an 8 mg per hour of continuous infusion of omeprazole, then there is an indication that okay, there's no more need of omeprazole infusion, but it could be switched to once daily or twice daily. And WBCs and neutrophils, you should know when WBCs are high or when neutrophils are high. Usually WBCs indicates kind of our infection markers. So when WBCs are high, we take it as that there are infection. It helps us to have to make selection of our antibiotics, but you should also look into account other drugs that could increase the WBCs level, like uh, steroids that increase your WBC's levels, that could take out from the blood. And if you are talking about antibiotics, then you should not rely only on WBCs. Check both WBCs and neutrophils along with culture report while doing antibiotics orders. For example, if you are going to use a broad spectrum antibiotic, and if there is an increase in the WBC neutrophil trends that is decreasing or normal range, then you could de-escalate with the help of using other infectious markers. Low values of WBCs may indicate prophylactic use of antibiotics, like if a patient has a WBCs of less than 1000 cells, then the patient has febrile neutropenia. ओके, चले। अच्छा, मल्टीपल कमेंट्स के हमें उर्दू भी बोलनी चाहिए। तो ये है कि जो WBCs और न्यूट्रोफिल्स का जो कम्बिनेशन होता है, उसमें ये है कि जब कभी आप एंटीबायोटिक्स की चॉइस करते हैं तो आपने उसमें ख्याल करना है कि जो है वो WBCs और लेट्स अगर एक पेशेंट के WBC लेस देन 1000 में, तो इसका मतलब है कि उस पेशेंट को फिब्राइल न्यूट्रोपीनिया है। अब आपको जो है न्यूट्रोपीनिया एक्यूट न्यूट्रोफिलिक काउंट कैलकुलेट करना होता है, जो कि होता है न्यूट्रोफिल्स की जो परसेंटेज होती है उसको WBC से मल्टीप्लाई करना होता है, लिमिट साइड। लेकिन दैट्स जस्ट फॉर, ये सिर्फ आपको बताने के लिए था कि जो है आप जो है WBC और न्यूट्रोफिल्स को यूज करें, ठीक है, इंटरवेंशन करने के लिए। अच्छा, ऐसी ड्रग्स जो कि आपके WBC या उनको बढ़ा सकें, उससे पहले फिर आपने उसकी डिस्पेंसिंग से पहले उसका ख्याल रखना है। प्लेटलेट्स की अगर बात करें, हमारे एक बहुत ही कॉमन चीज़ जो हमारे यहाँ पाई जाती है वो है डेंगू। ठीक है, कि डेंगू के मरीजों में जो है वो प्लेटलेट्स कम हो जाते हैं, तो हमें उन पेशेंट्स को जब भी कभी आप मेडिकेशन डिस्पेंस करें तो आपने इस चीज़ का ख्याल रखना है कि जो है ये जो हमारी ड्रग है वो WBC को, सॉरी, प्लेटलेट्स को कम ना कर रही हो। ठीक है, कि थ्रोम्बोसाइटोपिनिया तो नहीं कर रही किसी के, जैसे कि आप हेपरिन दे रहे होते हैं, तो हेपरिन इंड्यूस्ड थ्रोम्बोसाइटोपिनिया एक बहुत ही कॉमन सी रीजन है। तो इन दैट केस यू शुड बी केयरफुल अबाउट इट, एंड आल्सो अबाउट दो ड्रग्स दैट कुड जो कि थ्रोम्बोसाइटोपिनिया काज कर सकती हैं, जैसे कि लाइनजुलिन जो हम यूज़ करते हैं, एम्योड्रोन हम यूज़ करते हैं, अक्सर हमारी जो एंटी एपिलेप्टिक्स होती हैं। सो जो है इन तमाम की इंफॉर्मेशन आपको इजीली ओवर द गूगल आपको मिल जाएगी कि कौन सी ड्रग जो होती हैं वो थ्रोम्बोसाइटोपिनिया काज करती हैं। तो अगर आपके पास कोई पेशेंट डेंगू का है और आपको पता है कि लेट्स सपोज मैं इसको लाइनजुलिन दे रहा हूँ तो शायद इसको थ्रोम्बोसाइटोपिनिया ज़्यादा हो जाएगा, तो वहाँ पे आपने इंटरवीन जरूर करना है कि आपने जो है वो लाइनजुलिन नहीं यूज़ करनी। एल्ट्रेम्बोपैग दैट इज अ रिवोलेट, ये एक ड्रग यूज होती है जो कि WBC सॉरी प्लेटलेट्स को इंक्रीज करने के लिए यूज होती है। तो इसमें भी आपने ख्याल रखना है कि जब कभी आप ऐसी ड्रग दे रहे हैं जो प्लेटलेट्स को इंक्रीज कर रही है, तो अगर आपके प्लेटलेट्स 50-60 पहुंच गए आपके पेशेंट के, तो फिर आपने उसको रोकना भी होता है। ठीक है। अब अगर हम बात करें ब्लड शुगर की, तो डिफरेंट टाइप्स की ड्रग्स होती हैं जो कि ब्लड शुगर को कम भी कर सकती हैं और ब्लड शुगर को ज़्यादा भी कर सकती हैं। तो यू शुड नो, लेट्स सपोज ट्राइमेथोप्रिम सल्फामेथोक्साजोल, सेप्ट्रॉन जो है, ठीक है। तो सेप्ट्रॉन जो है वो हाइपोग्लाइसीमिया, सेप्ट्रॉन की सल्फर की मोइटी होती है, तो इसकी वजह से ये हाइपोग्लाइसीमिया का कॉज कर सकता है। सो आप जब लेट्स सपोज आपके पास एक पेशेंट आ रहा है और आप उसको जो है वो एक ड्रग दे रहे हैं, तो उसकी वजह से उसको हाइपोग्लाइसीमिया हो सकता है, तो आपने उसको बताना या वो ड्रग जो कि ब्लड को रेज कर सकती है। लेट्स सपोज आपके पास जो है COPD के पेशेंट्स आएंगे जो कि एट टाइम्स ऑन स्टीरॉइड्स या न्यू डायग्नोज हुआ है, या अभी कोविड की जो सूरत हाल है उसमें डेक्सामेथासोन 6 mg की डोज हुई है, तो अगर आप उस पेशेंट को जो है आप डेक्सामेथासोन देंगे तो उसका जो ब्लड ग्लूकोज लेवल है वो रेस हो जाएगा। सो इन दैट केस यू शुड नो कि मेरे पेशेंट को क्या ज़रूरत है। एंड आई वुड से कि ऐसा नहीं होगा कि लेट्स सपोज आपने किसी पेशेंट को ऐसी एक ड्रग दे दी जिससे उसका जो है वो हाइपरग्लाइसीमिया बढ़ गया, तो आप उसको डिसकंटिन्यू करेंगे। हाँ, अगर अल्टरनेटिव ऑप्शन अवेलेबल है तो आप दें, अगर अल्टरनेटिव ऑप्शन अवेलेबल नहीं है तो फिर जो है आप उसकी जो मैनेजमेंट है उसको थोड़ा सा बेटर कर, लेट्स सपोज इफ इट इज इंक्रीज इन डोज ऑफ इंसुलिन। एंटीकोगुलेशन प्रोफाइल फार्मासिस्ट के लिए बहुत इंपॉर्टेंट है कि एंटीकोगुलेशन प्रोफाइल को भी फार्मासिस्ट को पता होना चाहिए, जिसपे प्रोथ्रम्बिन टाइम, PDT, INR आपको पता होना चाहिए कि नॉर्मल वैल्यूज क्या हैं। ठीक है, आपको पता होना चाहिए कि मुझे कब प्रोथ्रम्बिन टाइप टाइम चाहिए होगा, INR मुझे कब चाहिए होगा। तो जब आप ड्रग डिस्पेंसिंग करें तो उसमें भी इन लेवल्स को कॉन्टिन्यूसली मॉनिटर करें। ठीक है। यूजुअली जो हमारा INR होता है दैट इज लेस देन 1.2 और 1 एक नॉर्मल बंदे के लिए, लेकिन जो पेशेंट जो कि वारफरिन पे होते हैं वो क्या होते हैं, स्ट्रोक आर्टरी फिब्रिलेशन के पेशेंट्स होते हैं, तो वहाँ पे हम जो कहते हैं कि थिन थिन ब्लड या पतला खून चाहिए होता है। तो इन दैट केस INR जो होता है उसके रेंज जो यूजुअली होती है दैट इज 2 to 3 का हमारे पास टारगेट होता है। और अगर आपका वो पेशेंट जो है वो स्टंट्स के साथ है एंड द स्टंट इज नॉट बायोप्रोस्थेटिक, इन दैट केस दैट इज ऑन टोटली प्रोस्थेटिक, इन दैट केस यूर INR जो होता है वो उसका टारगेट जो होता है वो 3.5 तक होता है। सो आपको नॉर्मल वैल्यूज की पता होना चाहिए कि आपने किस तरीके से उनको देना है। ठीक है। इसके अलावा जब आप हेपरिन दे रहे होते हैं तो हेपरिन के साथ आपने APTT मैयर करना है। अगर आपका जो है वो APTT जो है वो 100 सेकंड से ज़्यादा है, तो इन दैट केस क्या हो सकता है कि वो पेशेंट ब्लीड कर सकता है। जो हेपरिन की इन्फ्यूजन है इट इज़ नॉट रिक्वायर्ड फॉर सबक्यूटेनियस, जो कि हमारे जो हॉस्पिटल में या जो घर में ये लगता है कि सबक्यूटेनियस लगता है, तो उसके लिए नहीं, लेकिन जो आपके IV फॉर्म यूज होती है इन दैट केस यू शुड मॉनिटर APTT फॉर हेपरिन। और इसके अलावा आपको हेपरिन एंटीबॉडीज भी देखनी पड़ती हैं। लेट्स सपोज अगर आप, जैसे मैंने पहले बताया कि थ्रोम्बोसाइटोपिनिया हो सकता है, जो थ्रोम्बोसाइटोपिनिया, फिर आपको एक जो है एडुकेट अल्टरनेट लेना पड़ेगा। लेट्स सपोज इट कुड बी फंडापेरिनक्स और navigatin etc. So you must check APT before dispensing IV heparin orders. Always hold heparin continue if APT is greater than 100 second, and you should know कि APT INR किन किन ड्रग से बढ़ सकता है। INR लेट्स सपोज टेलवेनासिन के साथ ओरिटेवानेसिन के साथ बढ़ सकता है। इसके अलावा वो ड्रग्स क्योंकि जो होता है विटामिन के प्रोड्यूस होता है आपके गट बैक्टीरिया से, तो एंटीबायोटिक्स जो होती हैं वो भी गट बैक्टीरिया को किल कर देती हैं। तो इन दैट केस योर INR कुड बी इंक्रीज, बट जो कि वापस स्टेबल हो जाता है। ठीक है। APGs आई विल नॉट डिस्कस इट हियर, आई एम सॉरी ड्यू टू शॉर्ट ऑफ टाइम। सो नो आई वुड से कि अगेन मैं अपनी बात करूं कि कौन कौन सी लैब्स जो हैं वो एक फार्मासिस्ट को आनी चाहिए। तो ये हैं वो लैब जैसे कैम 7, CBC और FT और लेफ्टी कल्चर्स, TDM, लिपिड प्रोफाइल, डायबिटिक प्रोफाइल एंड कैल्शियम एल्बुमिन बोन मैरो डेंसिटी एंड कोagulation टेस्ट. So in summary, I would say that laboratory values help us to make our decisions. It helps us from selection of drugs, dosing of drugs, and therapeutic effects of the drugs. Always ask for necessary laboratory before dispensing or administering drug. Appropriate interpretation of laboratory values necessary before making any conclusion or intervention. And last, most important point, I would say that remember, always treat the patient, not the laboratory values. So this was all from my side. Thank you so much. Believe me, like me, you are fantastic. So great. Very, very awesome. There is very actually मेरी प्रेजेंटेशन थी ये अगर ये बहुत ही अच्छी हो जाती है, अगर इट इज एन इंटरेक्टिव प्रेजेंटेशन कि हम एक दूसरे से कुछ क्वेश्चन करते तो शायद हम लर्निंग ज़्यादा कर लेते. इन द एंड ऑफ द स्लाइड्स आई हैव मल्टीपल केस सिनेरियोज फॉर यू. अगर आप उनकी जो है स्क्रीन शॉट एक्सेट्रा लेना चाहते हैं तो आप उनकी ले लें. और मीनवाइल आई वांट टू आंसर क्वेश्चंस जो आपने पूछे. बट बिफोर दैट मैं जल्दी से जो है वो अपनी स्लाइड्स को एंड कर देता हूँ. मेरी स्लाइड्स यहाँ पे एंड हो चुके हैं, लेक्चर एंड हो चुका है. कुछ क्वेश्चन है, कुछ केस सिनारियोज है जहाँ पे आपको लेबोरेटरी वाइज हेल्पफुल होंगे. अगर आपको कोई भी इंफॉर्मेशन चाहिए, कोई आपका क्वेश्चन है तो आप मुझे ईमेल भी कर सकते हैं. इंशाल्लाह आई विल रिप्लाई यू. These are the cases. A 72-year-old woman with 60 kg history of hypertension has developed hyponatremia after starting hydrochlorothiazide 3 weeks earlier. She experienced dizziness, fatigue, and nausea. Her serum sodium is 116. Her blood pressure is 86/50. Hg and heart rate is 122 beats per minute. अब इन सब के मैंने सॉल्यूशंस भी ऐड किए हुए हैं, लेकिन इशू ये है कि बीइंग वर्चुअल एक अच्छी बात है कि आप लोगों तक पहुंचे जाता है, लेकिन एक बुरी बात यह है कि शायद सारा नॉलेज जो होता है वो शेयर नहीं किया जा सकता. सो नो आई विल कम टू योर क्वेश्चन आंसर्स. जो आपके क्वेश्चन आंसर्स हैं, there is a term that is question है, please explain ECG in details. So मोहम्मद, आपका जो क्वेश्चन है ECG in details, being a pharmacist हमें जो है ना ECG का ऐसा इतना रिक्वायर नहीं होना चाहिए. ECG को अगर आप देखें YouTube पे बहुत अच्छी अच्छी वीडियोस पड़ी हैं, लेकिन you should know rhythm. ठीक है, आपको रिदम को पता होना चाहिए कि रिदम क्या होती है. ठीक है, कितने बीट्स हैं एंड क्यूटी प्रोलंगेशन. आई थिंक सो ये बहुत ही बेसिक सी चीज़ें होती है जो कि फार्मासिस्ट को आनी चाहिए. इसमें हमारे लिए इतनी एक्सटेंडेड चीज़ें तो नहीं हो सकती, लेकिन ईसीजी हमारे लिए इतना ही है कि वेदर क्यूटी प्रोलंगेशन या उसका रिदम जो है आर्टिकल फिब्रिलेशन एटसेट्रा इन दैट केस. लेकिन अगर आप इसको पढ़ लेते हैं दैट्स वेरी गुड. सो प्लीज कैन. Sir, if we have diabetic patient with increased urination and increased BP, so can diet dispensed or not? अच्छा, जो आपके पास डायरेटिक्स होते हैं, ठीक है, ये होते हैं फॉर CHF. तो मतलब उस केस में ये रिलीव करते हैं कार्डियक लोड को. तो I couldn't get it. I think so. It should be dispensed. Diuretic should be dispensed. If it is for this patient, अगर उसको आपने लगातार डायरेटिक्स देने के बावजूद भी मतलब डायरेटिक्स की वजह से ही उसको यूरिनेशन बहुत ज़्यादा है, तो इतना भी नहीं होना चाहिए कि आप उसको बिल्कुल ड्राई आउट ही कर दें. लेकिन इट शुड बी डिस्पेंस. इट विल डिपेंड अपॉन द पेशेंट. आई थिंक सो. Question is which weight should be used for calculating creatinine clearance and which weight should be used for dosing. अच्छा, जो क्रेटिनिन क्लियरेंस कैलकुलेशन के लिए है, अगर आप कॉग्रॉफ्ट गॉल्ड फार्मूला को एक्सटेंडेड करके पढ़ें तो उसमें 3 तरह के डोजेस वेट्स की बात होती है. एक आइडियल बॉडी वेट, एक एडजस्टेड बॉडी, एक एक्चुअल बॉडी वेट, एक और एक होता है एडजस्टेड बॉडी वेट, आइडियल बॉडी वेट, अगर आपके पास जो पेशेंट होता है अगर उसका बीएमआई इज लेस देन 18, दैट केस यू विल यूज आइडियल बॉडी वेट। अगर एक पेशेंट का बीएमआई इज अप टू 25, in that case you could use actual body weight, और even up to 30 भी जो है वो recommended है कि आप actual body weight ही use करें। when it is more than 30, in that case you will use एडजस्टेड बॉडी वेट। एडजस्टेड बॉडी वेट क्या होता है कि जो आपका आइडियल बॉडी वेट होता है उससे जो आपका टोटल वेट होता है उसका 40% होता है। सो फॉर मी, if BMI is less than 18, you will use ideal body weight. If it is up to 30, you should use actual body weight, and if it is more than 30, you should use adjusted body weight. And which weight should be used for dosing? तो डोजिंग के लिए आपको देखना पड़ेगा कि आपकी ड्रग कौन सी है। लेट्स सपोज इफ आई से अबाउट कोलेस्टिन, तो जो कोलेस्टिन होती है वो जो है आपके आइडियल बॉडी वेट के हिसाब से होती है। हर ड्रग का जो एक अपना रेफरेंस होता है कि हमने किसके लिहाज से देना है, ठीक है। There is another question, what is LMWH, that is low molecular weight heparin, Clexane, enoxaparin जो होता है उसको low molecular weight heparin कहते हैं। Enoxaparin, fondaparin, these are low molecular weight heparins. Method for TDMs, I couldn't question whether laboratory के हवाले से पूछना चाह रहे हैं या क्या। I'm sorry to answer this question, I couldn't get it properly. Can you share those adjustment slide? I will try to do so. Might be if I will share my slide with you people. Sir, kindly share your email address. I have shared. Sometimes the drugs show QT interval prolongation in softwares, but those interactions are mostly theoretical only. What sort of pharmacy intervention would work in that case? ऐसा है कि जो सॉफ्टवेयर में बात नहीं होती मोस्टली। लेट्स सपोज इन केस HCQ की हम बात करें कि ये QT प्रोलॉन्गेशन के लिए था कि ये एजिथ्रोमाइसिन और HCQ कोविड के स्टार्ट में यूज हुआ जी QT प्रोलॉन्गेशन। तो हमने देखा कि इससे वाकई QT प्रोलॉन्गेशन होती है, लेकिन आपने एक थ्रेश होल्ड रखना है कि कितना QT प्रोलॉन्गेशन हो गया। इफ इट इज मोर देन 500 मिली सेकेंड्स देन यू शुड होल्ड, ठीक है। तो यू शुड नो कि कहाँ तक आपके लिए एक्सेप्टेबल है। अच्छा, आपने कहा है कि दैट माइट इंक्रीज यूरिनेशन मोर, ठीक है। तो मैंने आपको यही बात बोली है कि आपने जो है उसका बैलेंस रखना है। अगर वो पेशेंट एक्चुअली हम डायूरेटिक्स देते क्यों हैं? डायूरेटिक्स हम इसी वजह से देते हैं कि जो दिल के ऊपर जो कार्डियक लोड है वो कम हो जाए, ठीक है। लेकिन अगर एक पेशेंट ऑलरेडी ड्राई आउट है तो फिर आप उसको डायूरेटिक्स नहीं देंगे। लेकिन अगर उसमें इतना पानी है और आप उसको निकाल रहे हैं तो उसमें कोई फर्क नहीं। should probably check in case of antipsychotics. Acha, what values we should check in case of antipsychotics? It depends which type of antipsychotics you are using. Let's suppose if it is clozapine, then you should look for ANC, etc. So it depends upon the drugs. कौन सी drugs आप use करते हैं, SSRIs आप use करते हैं तो might be hyperkalemia हो जाए. So it depends upon the drug, which kind of drug you are using. From where we can study laboratory interventions, like from where to study lab values in details, any book or website. I would recommend a book named as Student Survival Guideline for Pharmacist. I think you'll like the site name है Student Survival Guide. That is an awesome book for such things. Not for such things, as a overall pharmacist, that's a good book for you people. Student Survival Guide. That's my recommendation. Which lab test is for uric acid? I couldn't get it. कौन सा lab test करवाना चाहिए? What can be most common cause of thrombocytopenia in children? Treatment. देखिए थ्रोम्बोसाइटोपिनिया होने की एक तो आपको ड्रग्स बताई हैं, उसके अलावा बच्चों में एक ये होता है कि जब आप डिफरेंट ब्लड टेस्ट ले रहे होते हैं तो उसमें भी जो है कुछ ब्लड लिया जाता है, इसकी वजह से ओवरऑल ब्लड लॉस भी हो सकता है। तो उसकी वजह से एनीमिया भी हो सकता है, थ्रोम्बोसाइटोपेनिया भी हो सकता है, माइट बी सम जेनेटिक रीजन एज वेल. That's all. So thank you everyone for this session, and होप सो कि आपने आज की एक्टिविटी से काफ़ी कुछ लर्न किया होगा. सो आई ट्राइड माई लेवल बेस्ट कि मैं जो है अपनी जो भी लर्निंग्स हैं वो आप तक पहुंचा सकूं.